Hello, my dear radiologists. This is Team 12, and today we'll propose a research idea on a new technique to help you in the diagnostics of breast cancer. This is the application of computer vision models. I hope this is an interesting one and will bring you some relief in this decisive work and more confidence in accuracy and efficiency of diagnostics. You must have known that the breast cancer is the most common form of cancer in the world in the women population, and the asymptomatic phase is the primary imaging modality for screening. However, previous research have found that the bias in our vision system will cause diagnostic errors from previously seen radiographs. Besides, mammography remains labor-intensive and has recognized limitations. Researchers have formed available mammography training datasets, while little has analyzed the improvement from the computer vision models with machine learning techniques to demonstrate high diagnostic accuracy in your evaluation of medical images. Therefore, we ask the question whether the computer vision models can help you make better diagnostic decisions on breast cancer, and roughly to what extent, based on the result from our anticipated experiment, will computer vision models contribute to the environment?
For the research questions, we would first like to state the main focus of our project, which is to explore whether the use of computer vision programs in mammography could help radiologists improve the accuracy of diagnosing breast cancer. Here, accuracy could be defined in many different ways. In our research, we will measure it by the number of correct diagnoses for the given mammogram dataset by individual radiologists from different groups. In addition to our main questions, we would also like to answer the following sub-questions using the data collected during this research. First, can the use of CNN-based computer vision model in mammography improve the efficiency of breast cancer diagnosis? Efficiency can be defined by different standards. One way to measure efficiency is to compare the amount of time radiologists take to make certain numbers of correct diagnoses. Second question is, what would be the financial benefit of implementing the CNN-based computer vision system? Financial benefit of the computer vision model can be explored in two aspects. First, we can calculate the time saved by the radiologist when using a computer vision model and correlate this data to the cost. The second aspect, we can estimate the negative financial consequences of an incorrect diagnosis and calculate how much computer vision can improve accuracy and help avoid such incident. The third sub-questions we have is, how do results vary among different groups of radiologists? Here, difference can be defined by age, medical training history, work experience, or whether previously received training on computer vision model. We'll explore deeper into this topic in the data section later on. Although the following questions will not be included in the scope of this project, we would like to potentially explore these topics in the future. We believe they are very important and highly related to our project. The first question is, will the use of this technology have an effect on the radiologist's stress level? It is important to understand, reading a large amount of mammograms for potential cancer diagnosis is a high-stakes, labor-intensive, repetitive, and difficult task. It is possible the use of computer vision in mammograms could have a positive impact on radiologists' stress level and long-term mental health. The second question is, will the effect of computer vision models on radiologists diminish after a set period of time? It is highly possible that the use of computer vision models is very effective at first when reading the first few mammograms. But would it remain effective as the radiologists read more than 150 of mammograms? I believe this is a very important question to explore when discussing the effectiveness of mammograms computer vision. The third question is, which computer vision approach will have a better result? CNN-based approach or the traditional CAD approach? Although the main focus of this study is to explore the use of CNN-based vision model, the traditional CAD has been widely used and adopted by the industry. We would very much like to explore the difference in the effectiveness of these two methods.
For the study design, we will divide all of the radiologists into the control and treatment group randomly. For the control group, in the pre-treatment stage, we will present a set of mammogram images toward this group of radiologists and ask them to classify each image without the aid of computer vision. And for the treatment group in the pre-treatment session, it will be the same. It will be the same procedure. They will read the same set of mammograms in a random order and then classify each image. However, for the treatment stage, we will do different assignment or different procedure for the control and treatment group. For the control group, they will read a new set of mammogram image and still without any help or suggestion from the computer vision models. While for the treatment group, in the treatment stage, they will read the same new set of mammogram image as the control group in this treatment stage, but now they will have the computer vision models, which will give them which will give the radiologist a prediction of what will of this model for the particular mammogram given, and then radiologists will be able to view this image together with a prediction, and then they will classify each image after this.
In our experiment, radiologists will be asked to determine whether a mammogram contains a tumor or not. We will collect accuracy scores from radiologists in this task. Radiologists have a very high workload and need to be able to quickly judge whether a medical image contains a tumor or not. However, the speed at which radiologists make these judgments may impact their accuracy, which is very important to avoid in this field. To understand the speed-accuracy trade-off, we also measure the reaction time in radiologist judgments. Radiologists that take part in this experiment will provide written consent before participation, and all experimental procedures will be approved by the UC Berkeley Institutional Review Board. One group of radiologists will receive diagnostic suggestions from each mammogram from a pre-trained computer vision model. This suggestion will come in the form of the probability that the mammogram contains a tumor. As stimuli for our experiment, we will use mammograms from the curated breast imaging subset. The mammograms are labeled as being normal, benign, or malignant, which serves as ground truth for our classification task. The original dataset contains over 2,000 mammograms, and because we most likely have limited time to test radiologists, we use the stratified random sampling technique to select 75 tumors and 75 normal mammograms. The reason behind using the stratified method is to ensure that there are the same number of mammograms belonging to each class. An important thing to note is that each mammogram's ground truth label comes from only one expert radiologist. This raises concerns about the validity of the labels and whether the labels contain human biases. One way to address this limitation is to generate our own ground truth labels by having 4 or 5 radiologists classify each mammogram and assign the majority class as ground truth. And we can do that as future research. To control for artifacts and potential confounding factors, we will also collect background data from the radiologists, such as radiologist age or number of years of experience with mammograms. I'll speak a little bit about the sample for our experiment. First, our population of interest here is radiologists that screen mammograms for tumors. Second, recruiting radiologists is extremely hard because of their high workload. For this reason, it may prove useful to coordinate for the experiment to take place in a convention that radiologists attend. Thus, participants will be recruited at the Radiological Society of North America annual meeting in Chicago, and our sampling technique will be convenience sampling. We will recruit radiologists that are available and willing to participate during the convention. This technique is prone to volunteer bias since radiologists that we sample may be different than those that choose not to. By collecting data on the sampled radiologist backgrounds, we will be able to some extent control for sampling limitations. Our sampling frame is radiologists that attend RSNA, and in regards to sample size, our goal is to recruit 30 radiologists in this experiment in line with other experiments like this.
Here, I will talk about the variables used in our research. In our research, there will be one control group and one treatment group. The control group will be asked to give diagnosis to predefined set of mammograms images without the help of computer vision. The treatment group will perform the same task, but will receive diagnostic suggestions for each mammogram from a pre-trained computer vision model. The suggestion will come in the form of the probability that the mammogram contains a tumor. Assignment to the treatment and control group will be determined by stratified sampling based on background data collected from the radiologist, as described in the data section. During the experiment, we will record the response time to diagnose each mammogram and the accuracy of the given diagnosis by individual radiologists from both groups.
For the statistical methods, there are 3 parts of the analysis that we plan to do. The first part is the most important part, which is what we care about, whether computer vision models could help radiologists to improve their accuracy. So we will conduct a different indifference method. So basically, we will compare radiologists in the control group and the treatment group to see whether radiologists in the treatment group, so with the aid of computer vision models, will have a significantly higher improvement in their accuracy compared to the baseline, so compared to the pre-treatment stage. And then we will also do the analysis on response time. So we will use t-test for the treatment stage, for the treatment session, to compare whether the control group and treatment group radiologists will have a different response time. We assume that this could help us to test whether computer vision models could help radiologists also to make quicker decisions. And the last statistical method that we plan to use is to estimate speed accuracy trade-off. So usually when radiologists are responding faster, they usually make more mistakes. And this is the speed accuracy trade-off. So we will actually fit drift diffusion model on the control and treatment group to compare whether their responses in the treatment session has a different speed accuracy trade-off. Or to specifically, we want to know whether the use of computer vision models could help radiologists in the treatment group to have less speed accuracy trade-off, so they can be both accurate and fast.
To give you a thorough understanding with this proposal, we also list some possible risks. From the scientific validity aspect, what is the importance of radiographic diagnostic results on breast cancer? Is it the decisive method, or can it be diagnosed by other means, such as clinical symptoms? The answer should justify the importance of our research. The accessibility and quality of existing radiograph datasets remains a risk. The results will be influenced by subjects' previous study on the datasets, the clinical experience of the subjects, and the advancement of machine learning results. Since our conclusion is based on experiment of 2 groups of radiologists, there is also difficulty of sample framing to generalize the results. Then for the stakeholder, how should hospitals make trade-offs between hiring more experienced doctors versus purchasing machines to help diagnose? Does the benefit of this research outweigh the input and impact to conduct it? Last, like many other ambitious research, there's also law and ethics risks. If the doctors rely on machines to diagnose breast cancer, will it go against the wishes of the patients? And will our findings lead to unemployment issues?
Hi, so here are the deliverables for the rest of the term. We separate our milestones to 5 different steps. Each of them are intentionally into smaller chunks. So we decided to do data collection for step 1, snowball interviews, which is meaning that we want to interview 1 person at a time, and we want some referrals at that point, so you will branch out to a different industry. And later on, we're going to do some data analytics, and then there's going to be modeling and prediction. We built a machine learning model on the vision with computer vision. And lastly is going to be a final presentation. The deliverables are also going to be separate in 5 different parts, ranging from raw potential to interest areas to all the way to a very detailed summarized report on the specific findings. And thank you very much for listening. We also have a very potential next step after the whole 5-step milestone. That's going to do some experiments. And here are our sources. Thank you very much.